It's lovely to be able to connect with people all around the world, and I'm so excited just to be able to chat to people. So when anyone jumps on anything I've said and is like, hi, I'd love to talk to you about that, I'm like, woo, let's talk more.
Yes, it is very exciting because I think, like you and I were messaging, it's interesting world that we're all living in right now, because a lot of the new research that's coming out, particularly regarding pain, is new and is not applied specifically to a pelvic pain population.
Yeah, we're completely making it up at the moment.
We're making it up. And so we're like pioneers in this fun field, like practicing, and our patients are these guinea pigs,
in the nicest possible way. I could see the pain in your voice as you said that. Oh,
I know, though, patients like it though. I mean, my patients, when they come in and I have something new that we're doing, they're always like, oh man, here we go. What are we doing today? But they know it comes from a place of research and, they're
exactly. And if you're always honest that we're kind of, this has helped a few people and we're not really sure. So there was a chap today that, I've been playing. I don't know if you read some of the comments I put up, but I go to our global group for help all the time. And I've got a lady with a suprapubic catheter that we're trying to get rid of. And she's got a really poor contractility of her bladder. And so Fiona Rogers suggested that I use one of these bladder stimulators. I don't work in a neurogenic population, so I haven't come across them before. And thank goodness they're only £30, which is cheap. So she started using that and she's already got an amazing benefit from it. But it's basically
a bladder stimulator, like a spinal stimulator, like an inner stimulator?
It's like a vibrator that you put on your bladder as you have a wee, and it stimulates tonic activity of the bladder. I know.
I have not heard about this.
Neither had I. Fiona Rogers, thank you very much. But it's amazing because in the one research trial that was associated with it that I pulled up and found was in patients with MS that had sit still. Sorry, the cat Jens is going to join us. If you're going to join us, you've got to sit still. During the research trial, they had ladies with an average post-void residual of about 160, and using the stimulator for 3 months, where they place it while they void, and then after, for up to a minute after they void, and they found that the post-void residual reduced to an average of something like 67, which is fine.
That's incredible.
I know. And if we can get her post-void residual to less than 100, then we can get the catheter taken out, and then everything's fine and she doesn't have to use ISC. But so I was trying to apply that this morning to another chappie with another neurogenic bladder issue where we haven't got that contractility. And it's the one thing that we never train is within physio. Certainly I haven't, because I don't work in that neuro population. And there I am saying, well, we've got this one study that I'm aware of. And I've got one patient that I can reflect upon that we've had some success. She's already gone from, we had post-void residual of about up to 200, 300 mils, and then voiding was about 50. She was using a suprapubic catheter to empty. And now we've flipped it. So now she's voiding about 150 and she's flip flowing 50.
That's pretty incredible.
I know, just with like 6 weeks of the bladder stim.
What's the name of it?
I can't remember, but okay. I'll send it to you. Please
do, because I periodically treat patients who have difficulties with emptying, and similar to you, I don't see a big neurogenic population. However, I'm wondering how it would work for people like the patient that you described. I mean, I have some different patients. Yeah, my brain's thinking about a lot of things. Cool. Yeah, I like it.
Well, there we go. Fiona Rogers, thank you very much. So what are you doing with pain? Because as we talk about pioneers in pain, the stuff that you're telling me via your messages was really interesting. And I thought,
it's so it's very much so. My little caveat is that I am very much in the learning stages of all of this, and so it's like you said, like it's pioneer things, and I'm very, very fortunate because I have a very nice group of clinicians who I share. We share space together at a practice, and I have people, so I have someone I work with who specializes in vestibular dysfunction. And so she, we've seen some interesting things. And I have another colleague who specializes in chronic pain, and his name is Seth Oberst. And I think I shared
some of his blog posts. He's really lovely.
Yes, he's fantastic. And he's very interested in stress and how stress impacts movement. And so it fits really nicely with the population that I work with. So we tend to co-treat back and forth. And so some of the things I'm going to share, that's my caveat to say they're not new. They're not mine. They're just things I'm trying to take and put into a pelvic pain population. So
yeah, and there's so much that we're all doing all the time, but the only way we can do it is by
learning
learning from each other and saying
collaborative, and it's really cool. And so basically, what I've been trying to look at is, if we think about how the current understanding of pain, that pain is an output of the brain, that people develop these neurotags associated with their brain, and have certain patterns in terms of their sensory input that can facilitate those pathways. And so what we've been trying to look at is how can we impact that? Can we use other sensory input that might put them into a little bit more of a relaxed, that parasympathetic state, and would that translate over into their pain activities? So we've been doing that a few different ways. And so, I loved what you shared about that scent, olfactory input, because I think that's so powerful. When you were sharing that, I was thinking about, I had gone to Mexico recently with my husband for a little anniversary trip, and we walk into the lobby, and there must have been some type of lavender or something in the air, and we were like hungry and tired and stressed, and they made us wait for like 30 minutes to check in, but we're like, lavender. Like we're like relaxing.
I'm total relaxed. Yeah, great.
Yes, and it was incredible. And so I've been playing with that a little bit with scent. And so for some of my patients, like I have one, for example, who struggles a lot with having with pain during penetration with her partner. And so one thing we have been doing is using some gentle self-internal treatments in a very minimal discomfort way, and having something going on at the same time. So she is diffusing, has her favorite candle lit with a nice smell while she's doing that. She's breathing, relaxing. She's also listening to some gentle music. And so we're trying to do that for a period of time. And then what we're going to do is take those pieces and then put them into a situation where she's being intimate with her husband. So
how long did it take you to get to for her to be comfortable with, even with self-touch? Because I can see that that might itself be a graded exposure program of just lying there with the scent and the music. Like, how did you approach
Absolutely. And so I think that's going to vary a little bit per person and for their particular experience. She was really interested in going to that really quickly because she had such a big goal to be intimate with her partner. And so we started it fairly early. Once, the way I tend to do that is once I feel like we can, in a session, they are with me doing some internal type treatments, and she's really, able to relax during that and, feel comfortable, not feeling anxious about what we're doing or anything like that, then we start trying to do some at home in a way that is safe. But I think for other people, it might be that they're using a candle and music and maybe just doing like a guided relaxation or something first, and doing that for a period of time to try to establish this as to establish something that will help their brain get into that relaxed state.
So that's really interesting, because I've been playing with that as well, and I've not got it from anywhere, but I kind of been thinking that putting yourself into a bit more of a parasympathetic activity I say to patients, is a bit more malleable a position. We can mold, we can change when we're in this state where we're a bit more relaxed. So you're always doing relaxation before you then go on some kind of treatment.
I think from what I've seen, I feel like it's really important to get someone into that state before their brain will be able to carry over that. Because I think I was actually talking with Seth probably last week about this, and what his thought with this is going is that if we push this too quickly with patients and it's a negative experience for them, then that thing that we were using to try to change that neurotag might just play into their pain neurotag, and we lose that benefit.
Yeah, especially if they're spending the whole time going, this is not painful, this is not my pain, my pain, or thinking about their pain. They've got to be, this is a completely different thing I'm doing. Unfortunately, in what we're trying to treat, it inevitably becomes about the pain sometimes, because they're always thinking, oh, well, I don't want this to hurt, I'm scared of this hurting, I'm scared of this setting something off. I get
Yes.
a lot that patients are really, you know, they're always thinking end goal of penetration. It might have been that penetration started the pain originally, or it's always been painful with penetration, and they're thinking, well, I've got to get there, and you're like, no, this is just the halfway steps to be able to get there. But I find that if they're focused on their pain, and I'm not able to just go, we're going to do something different, even though in my mind I'm like, right, this is our chain, do something different that's just going to feel good and feel relaxed, and because you can get them too focused on that pain.
Yes.
And then the neurotags don't build, and we're using the same ones, which just threat, pain.
Yes, and then all the work that you have done, you end up losing, and you almost have to find something different to start over, I guess, in some ways. But I think I've seen also this being a big problem with postpartum populations. So I've seen a lot of women after they've had children, you know, especially if they had some type of perineal trauma, that part of their body starts being perceived as really dangerous. And I think that there can be a big barrier with that to returning to any type of enjoyable penetrative activity or sexual stimulation down in that area because of how dangerous that whole experience felt to them.
And it's huge if you think about any other area of the body that goes through such a emotional and physical trauma.
Oh yeah.
I mean, apart from if you are particularly a sports person who maybe has the emotional involvement in, say, like a tennis player with a shoulder, just an example, that then dislocates a shoulder. So you'd get the physical trauma and the emotional overlay of a loss of career or something. You know, comparing the vaginal trauma of a delivery to any other kind of injury that we treat it's massive.
Yeah.
You know, we need to be dealing with that emotional side as well, because we know that neurotags are built on it. And we know pain is my favorite paper, currently favorite, Rapares Gonzalez 2014, which talks about emotional processing and emotional production causing an increase in bladder lining inflammation. When I like to quote patients that say, we know that emotions cause changes in your pain state and changes in your actual immune system response. So if we're not dealing with the trauma of something, then so do you guys get access to have you got really good links with like counselors and other therapists?
Yes. And so I think, you know, I've been fortunate here in, you know, I'm in Atlanta, Georgia in the US, and have built relationships. We have a great organization, particularly that's specializing in working with the mental health of women after having children. And that group has been really great. There are like 3 counselors that I have connected with who are within that group. But then other counselors, you know, we have a few people in the area who specialize particularly in trauma. And it was interesting as you were sharing, you know, mentioning your recent favorite study. One of my favorite studies, which is a little bit older, so it's published in 2001. And of course, the name of the author starts with a V, but it's leaving my brain right now. But it is looking at the response of the pelvic floor and the upper trapezius muscles to threat or to perceived threat.
Was that the study about the watching horror films?
Yeah. So they watch video clips. Yes, it's fascinating. And so people watch these video clips, and there's, you know, one that's fairly innocuous. There's an erotic film that they watch, a threatening, and then a sexually threatening film. And they were comparing population who had vaginismus to a population that did not. And what they saw was that the group that had vaginismus and the group did not both showed increased EMG activity of the pelvic floor and the upper trapezius when they watched both threatening and sexually threatening clips. And that I think is very fascinating because, you know, when we think about traumatic situations, so childbirth that involves direct trauma to the pelvic floor in some cases, but also could be emotionally traumatic, which could induce that state, that response of contracting and gripping. And so when you think about that piece pairing into the pain science piece, it's just super interesting. And I think that, you know, with the childbirth and that, you know, related trauma, I think that has only recently been validated for women to where they actually feel like they have a right to feel like their experience was traumatic for them. And I think that it's important for all of us to understand that trauma does not have to be, you know, people think about like sexual trauma or physical trauma, emotional trauma, but trauma can be so many different things. For some people, it's, you know, I had a patient that it was witnessing a car accident that sent her into this state that she couldn't get out of. I teach for Herman and Wallace in their pelvic floor series here in the U.S. And recently we were at an intro level 1 course this past weekend, and I had a participant after our sexual trauma lecture who was talking to me about her own medical experiences. Mm-hmm. And as she was sharing it to me, I told her, what you went through, that's a trauma. And she was shocked by that and started crying and saying, that she never in her mind validated that could be a trauma. And I think we see, so, I mean, I've digressed away from this history stuff, but it's super interesting.
It is. And the thing is that I think, there's lots of examples this week. I have two new members of staff that are great. They've been working as physios for a long period of time, and they're really getting to grips, but they're kind of just new-ish to pelvic health. And what we've talked about a lot is that kind of, where is our scope of practice, and where do we flip over into counselling, which is not our scope of practice, but how much that you need to be working with people, and you need to have a certain degree of understanding and those communication skills, which are really hard sometimes to teach. That if you I think certainly that all of the pelvic health physios I've come across are incredibly empathetic and incredibly almost real kind of gymnastics at being vulnerable and being in a very vulnerable space with someone, and that you're very comfortable in being a really horrible space with someone. And I think you have to be, because actually if we're going to get people better, you have to take into consideration all of these things. We don't necessarily have to be treating the trauma, but we have to be picking up on it and saying, have you considered that actually that there's 4 times in the last hour that we've talked about this particular incident? Is that something that maybe you might want to talk to someone else about a bit more? There's a couple of times this week, and actually a couple of patients come to mind that have tapped back into me, that you kind of, the repeat offenders, but they're not repeat offending, they need some support, and they come in. So one of the girls that came from my trial was completely fixed. She came back a while afterwards and was like, I've got bears everywhere, I don't know where the bears are. Because I use the theory of like, your body feels like it's got bears attacking it, and we've got sympathetic, parasympathetic, and it's just kind of not a scale, no shades of grey. It's either a bear is actually trying to bite your vagina, or a bear's not biting your vagina. Mm-hmm. And try to get them to identify other bears in their environment. It's just a simple way for patients. So she was just,
I love it.
I can't find the bears, you've got to help me. And I said, right, okay, well, let's talk about it. Let's start with life. How's partner, how's all the rest of it? And we worked out that actually she hated a job, she was being bullied, and she needed to leave a job. So she'd got suprapubic pain, bladder pain, urgency frequency, it all come back. She was really, really stressed. I did one treatment, which was much more of a therapeutic assessment. These days I just do lots of touching, which is is this acceptable to you kind of assessment, rather than I'm going to do some myofascial release, or you do some trigger points. It's none of that. It's like, let's try and get this system to calm down a bit, and let's get you to feel supported in this moment. And then she came back the next week and was like, yeah, I'm fine. She decided that she needed to start looking for a new job, and as soon as she'd made that in her mind, she came back and said, actually, just talking it through with you made me realize how unhappy I was with my job, and how my body was expressing that as suprapubic and urethral pain.
That's amazing.
Yeah.
Oops, sorry.
That's all right. Coming after you.
There you go. Sorry, phone ringing.
And then there's been a couple of people in the last week or so that have had injuries where the body has given them a disproportionate amount of pain as a response. So I've got somebody that's come off, fallen over and hurt their pelvis, and suddenly all of this endometriosis pain is back, and huge amounts of stuff. And we spent one session discussing it, calming everything down, doing some calming stuff, doing some self-care, and she's lots better in a week, and it's just switching off. And now we've got an appropriate level of pain related to an injury rather than a big flare. So it's those kind of juggling skills that I think you have to have. And I don't know, from an American point of view, I'm getting a bit more of a perspective every now and then, the more people I talk to. But within the UK, we have a very regimented view within our National Health Service of what we do within physio. And I jumped ship. I did 10 years in the NHS-ish, and I jumped ship. And just to kind of expand, my scopes remain the same, I treat the same, but I always feel like I've got a bit more freedom to sit down with someone and just say what's going on, because I haven't got the pressure of someone saying you've got to get them out in 6 sessions. My patients are still, my average treatment is still 4.2, so I'm still getting people out really quickly, but just sitting there and saying, what's going on with you? How are you doing? Where are the bears? Let's talk about bears if you need to understand it in that way. What else can you do? And actually kind of thinking outside the box. There's one girl that she had a lot of things in a prior history, and we discussed her main, when she'd come to physio, her main goal was to become a nurse, or a teacher. I can't remember, it might have been a teacher. We basically did career guidance. I helped her write her UCAS statement.
I love it.
I was like, homework, right? You've got to do this. You've got to find your skills. You've got to do that, because actually she just needed to focus on something that wasn't her pelvis. I couldn't even touch it, couldn't look at it. And that got better. And her focus was to get into university to do those things. So I think we work with humans, don't we? So we have to be good at understanding humans, and also being flexible about knowing, opportunities for humans to thrive. And quite often when you're in a treatment role, you can kind of get stuck at going, right, this bit hurts, so I'm going to treat this bit. Whereas some of the time that's great, and some of the time you just need to go, this bit hurts, but what's going on with the whole person, and how can I make them feel better?
Absolutely. And I think, we in the US, I think part of similar, like you're talking with working with the NHS than being private, it's similar here in working with insurance companies, and then people who choose to be out of network, being more of a cash-based provider, having a little bit more freedom. But I think that you're right. I think, looking at the whole person is so important. And, the truth is that, like your patients that you shared, what is happening outside of the body is often equally as important as what's happening in the body, and often very interconnected with that. I was thinking about, as you were talking, a patient of mine who was younger. She started seeing me, she was 17. She was a junior in high school, started having really, really severe pelvic pain. And I ended up referring her to a specialist in the area who's an excellent endometriosis surgeon, and she ended up having an excision surgery, did really well after that, recovered really well, everything was great, but then returned back for her senior year of school. And I got an email from her very shortly after starting school. She ended up coming back in to see me, and we started talking about it. And it was interesting because what she ended up discovering through, conversations with me, conversations with the surgeon who had worked with her, was that junior year that was so traumatic for her, with having pain, missing classes, the academic pressure still being on. When she went back into that environment, it ended up triggering these same pathways. And she felt, as if her pain is coming back, but really it was that her body was not feeling safe in that environment because of everything it had been associated with. And so she ended up switching gears completely, and ended up doing her senior year a combination of some different homeschooling things, online education. And once she made that decision, she started working with a great counselor, because she really didn't need me at that point. She needed counseling to help her with that. And she did fantastic. And, I saw her for a session or two to help manage more of the musculoskeletal sequela of what was happening and help her with that piece. But everything just fell right back into place. And so it really can be so powerful.
Oh, it takes me back to what we were originally going to talk about with motor imagery and neurotags, but the environmental creations of neurotags, environmental neurotags. And I see that so often in patients. There's a patient that's had extensive surgery, and there's a staircase in one of our local hospitals that she can't get past. Every time she gets to that staircase, she feels breathless, she feels unhappy, and the pain starts, and it's a big stress. We've talked about being in the hospital, but it's that staircase. So actually, how do you approach? Are you doing any kind of graded exposure to these kind of things?
Yes. So I'm playing with that too, from a movement standpoint. Trying to, I like the principles of taking tasks and breaking them apart into pieces that are manageable. I have a patient I'm working with right now, where if she's watching this, she's going to know exactly who she is, but she has pudendal nerve pain. And we've talked a lot about the fact that for her, it tends to be an all or nothing type thing. So she will either be at home in bed all day, you know, or she'll choose a day to go out, and she will go out and be gone from the house all day, really, really active. And, you know, she was sharing with me, well, one day out means 2 days in bed. And so we've chatted a lot about how do we change that? So how do we break apart this big thing of being active all day to manageable pieces of what can you do? And I think that that is graded exposure to activity, you know, even taking the idea of being able to sit for a meal. Well, maybe sitting for a meal is too long, but maybe could you go and meet a friend for a glass of wine, and maybe just have that short little hour and a half that you're together versus like a 2.5, 3 hour long meal. And I think that when people can break that apart, it helps a lot.
It does a lot. I mean, from a physiological point of view, the evidence coming back about kind of nerve hypoxic states and kind of the long-term damage that can be reversed. Something I was reading a while ago, and that's really nice. Since that kind of graded exposure builds that resilience in the neural system, let alone in the neurotags, kind of saying, well, actually, can I have a different experience that is not noxious? And I experience something that feels okay and that astounds my expectations. But I like that, glass of wine, because then they can perch as well if they're at a bar.
Yes, they can, and they can stand at a bar, you know, where maybe there's a stool that they can lean on instead of feeling, I don't know. I mean, I have a lot of my patients who choose to just eat meals at bars where they can just stand at the bar. But that, at least, you know, to me, that also is part of that slow exposure, because it's taking them from I can't do anything at all to try to figure out what can you do. And you know, and I think that that's part of what we can do is brainstorm with people to try to figure out how can you live your life still within the constraints that you may have now. But hopefully as we work together, we're slowly, you know, widening those constraints so that, you know, they're able to do more and, you know, maybe sit longer, maybe, you know, perch differently, or, you know, change up that activity.
It's, I love the bit when someone comes into you and says, I can't do anything. It's you don't understand, and you go, I totally understand, and I understand that you're in pain, can you lift your arm up? And they go, but it's about my pain. You break it down, and then suddenly they're, you know, on their side, they're doing something, they're, you know, finding, I think physios are really tenacious finding the one thing that people can do.
Yes. So and one of the things I've worked with some of my patients on with that. So I've worked with some people who have pretty severe pain to the point where they've had to stop working. And I think that for many people that's this other big thing, because now, you know, you were mentioning all the bears in the room. I mean, when you stop working and then suddenly you're not bringing in that income, that becomes another bear. And then you feel like a burden to your family, and that's another bear. And you feel like, you know, and it's just all these things, like you're not being a good example for your children, and you're, you know, and it's just goes again and again and again. And so one of the things I've been working with my patients with that on is trying to do things like volunteering. We have a great organization in Atlanta that's called Hands on Atlanta, and it's this in the metro city area. It's this website where you can go on and you'll see all these volunteer opportunities, and you can choose something that's just an hour long, or you can spend a half a day. So working with people to say, okay, well, you can't work, but what can you do? And trying to get them out of their house, out of themselves, and out back into the world. And I've had some patients too that while they've had pain, they'll go ahead and take on, you know, doing some other thing. Like one of my patients started selling makeup, and, you know, and she knew, you know, that this is not going to be something that I'm bringing in tons and tons of income for, but it's something that gets them out of like their brain focused, thinking about their pain all the time, and into a different, into thinking about other things.
And showing that the brain has options. So again, there's all that work, the MAP Research Network are looking at, Jason Kutcher's team looking at variability, and that a brain with the ability to do lots of different things is a better predictor of going to improve. So that someone with a kind of cognitive flexibility, the words are not coming today, with better cognitive flexibility is able to improve in their pain, because actually the brain doesn't just want to be focused on pain the whole time. It makes me think as a patient that when sometimes I think in the end, as a younger physio, I used to be a bit like, I think I'm just doing crazy things, but it made sense for my patients. And you're kind of like, I'm making stuff up, but this is actually working. There was one lady that she was very, very good at sewing, and it was the only thing that she felt she could do because she could lie back while she did it. And she'd sew things for babies and kind of like really nice cute dribble bibs and things like that, and hats. And we got her in doing an Etsy shop, so she kind of sells online. She had her own income then. It was a little bit, but she was really proud, and wasn't making it for her friends. And that completely switched her outlook, and actually made her brain, I think it's about putting it into that parasympathetic state, where it's more cognitively flexible, so that you can then do stuff that isn't pain. Sorry, the cat's shouting at me. Animal, he's very needy. Come on, there we go, pretending like it's time to be fed. So she was that cognitive flexibility. There's also this thing recently, I was on a retreat, which was lovely. I think we should all go on retreats, especially when you deal with pelvic pain all day every day. Exactly, if you're living it or treating it, we should be on retreats. And we were talking about mindfulness, and we were doing lots of mindfulness, and there's research showing that being in the state of deep thought, that kind of flow that you get when I get it when I'm writing, or when I'm writing or I'm planning, or like I'm writing my courses and that kind of stuff, or researching, where you just you're doing something for an hour or so, and you forget the time, you just don't realize, and you're totally in the moment. Sit down. If you're going to be on my knee, sit down. Come on. And that moment when you're in the flow is actually akin to a meditative state, and it has the same amount of benefits. So the same blood flow, the same cognitive flexibility, the bilateral use of brain, which is really key. So we're not just having one area. And so getting patients into more of those situations is key. So one of the kind of frivolous, he really loves me.
He does love you so much.
Yeah, you're a good boy. Well done.
I think he has some things he wants to add in about pelvic pain and what
he does. Mostly that he needs feeding, and that will make his pelvic pain better, probably. You kind of add it in. I think I used to add it in frivolously to the end of a session with patients and be like, I'm going to do these things to you, and you're going to do these stretches, and then and do something that you enjoy in life. Whereas now I'm much more like, what's your goal? And Sandy Hilton talks about, I was on her course recently, which was great, about pelvic neurodynamics. And she talked about patients' goals. And when you say, what are you looking to achieve with physio? And they go, I don't want to be in pain. And that isn't really a goal for life. Mm-hmm. Not being in pain. Nobody gets up in the morning. I know lots of people do, but no one gets up at the beginning of their life in the morning and says, I don't want to be in pain. It's I want to be a doctor, I want to be creative, I'd like to have a family, whatever the goals are. And that finding those deeper goals to people beyond what they're suffering at that moment is really key to their development beyond the pain. And actually all of this science is backing that up now, that kind of meditative states and getting that parasympathetic activity, so that we can get that kind of cross use of the brain that then doesn't just focus limbically on you're going to topple things over. Oh, Animal, he always does this every time I talk to anyone. It's like that is really international energy.
That's super interesting. So it's have you done much with binaural beats?
No, what's that about? Okay. I did download it when you told me.
So I'm really interested. That's something else I've been interested about that I have played with a little bit for patients. And so the basic concept with binaural beats is that, someone is listening usually with like earbuds. So they're listening to a sound, and there's one frequency through one ear, one frequency through the other. And it produces this auditory illusion because the brain will not hear two frequencies, but rather will hear the difference between the frequencies. Okay. So what they're doing with that is using binaural beats to elicit a frequency that, particularly there's one theta, which is actually a meditative state for the brain. And so it is, by listening to that, it induces this frequency of theta that can actually retrain brain waves to be into a more theta state. And they've done some interesting studies on it. So there was one that I found recently that was just published in 2018 that was looking at using binaural beats for individuals with chronic pain. And they actually found that over a period of them listening to that for 20 minutes a day, it led to a decreased pain perception. And so I've been playing with that a little bit with having some patients listen to that. And so it's really cool. There's an app you can download that's called Binaural, and it's free. And you can, there's an alpha state, which I think is more of like a sleep state, or maybe it's alertness. Theta is more of that meditative
scale, isn't there?
Yes, there's a scale. There's a scale. And so theta is more of that meditative state. And so what I've been doing for some patients is having them listen to that before they go to bed, just trying to get more of that theta meditative brain waves going. And I had one patient that it actually worked really well for. So she was interesting. She was seeing me, initially was referred to me because she had painful penetration, and that was her primary complaint. But while we're talking together, she shared with me that she also struggled at night with just this hypersensitivity, hyper awareness of her genital area. And we would joke and call it restless vulva syndrome, because we would be getting ready to go to bed, and it was like, I just can't stop thinking about my vulva. Like, it just feels like I need to move, I need to shift, I need to twist. And to me, it just seems this almost like hypersensitive, hyper-aware nervous system. So one of the things we started doing was at night when she would lay in bed, she would spend 15, 20 minutes and put her earbuds in and listen to that theta meditative state. And it was amazing because when she did that first, before going to bed, her vulva would bother her way, way less, and sometimes not at all, compared to when she wouldn't do that. And so I think it's interesting. I think that's something that we could start using for patients, even, in a workplace when they're going to be sitting at the computer, to use that, put that in for 20 minutes just to induce those brain waves. So I think it's something that's going to be studied a bit more. I don't totally understand the mechanisms behind it, so I'm still learning about it, but I think it's really fascinating.
That's really, really fascinating. Thanks for sharing. I think
absolutely.
That's got a huge possibility. Would you be able to send me the reference, and I'll put it?
The study that I mentioned.
Yeah.
Yes, I'll definitely send that. And so they did it. I mean, theirs was through a computer program, but I have my patients just download a free app and use that, and that works really, really nice.
Because I'm guessing it would work. I mean, I work a lot with bladder pain patients, and I'm guessing that would also potentially work with that constant desire to void.
Yeah.
And if we could couple it with other things, so going back to what you were saying about getting into that kind of restful meditative state, so that period of time, 10 minutes, 20 minutes during the day, where you could listen to some nice music, put on a diffuser, have some nice smells. I like smells. I like oils, because they just kind of, because we use essential oils so much during spas or other treatment, like you were saying, that you can remember the smell of it with Mexico.
Oh yeah.
There was on our honeymoon in where were we? Indonesia. There was a hotel. I know, it's lovely. Just before it started all blowing up because of the volcanoes. A couple of years ago, there was a beautiful, beautiful smell in the hotel, and I can still remember it because I just loved it. And I found a massage oil recently that really brings back the feeling of complete relaxation and luxury in this hotel in Indonesia. And because scent is so impressive and important in our brain. So thinking about using binaural beats with a nice smell regularly, so that then maybe they could plug in during the day if they're on a desk job. I've got quite a lot of people that kind of, because there isn't a regular break during their day, that if they don't like their job and they're not into it, that they then just get this constant constant feeling they need to go. So it would be almost like another version of TENS, because it would be an input.
Well, and if you paired it with the smell, then, that might, I think we all can think of times where there's a smell that triggers this big, these things in your brain to go off, whether it's from remembering a certain time, like your honeymoon, or like, for me, that lavender in Mexico. But even as simple as, I remember there was a perfume that my grandmother always wore. And if I smell that perfume, you're like back in her house, like thinking about all those things. So if we could use smell with binaural beats, could we then create a connection so that that smell helps their brain go into that theta meditative state more? I don't know.
And that's interesting. Gillian McCabe, my business partner, and she's just opening up a new clinic, and we talked about using diffusers and making it smell nice, because in the place that we have been using, we can't really do that. It's a bit more of a medical office. And it's kind of like, would that create it would create a lovely atmosphere and create a lovely smell. Whether or not that would bring back the thought of treatment to patients if they then carry that through. So if they have a good experience of treatment, then that would be a positive thing. But obviously, some patients don't have a good experience of treatment, so and treatment's quite traumatic for them. So but yeah, that's great. I'm going to start using binaural beats with my BPF.
Yeah, try it. It's cool. It's I've had patients that really like it, so it's fun.
I tried it on my phone and was just like, this makes a really weird noise.
It does. Well, and that's what they actually said in the studies, that some patients found they didn't like listening to the sound because it is kind of this weird, like, this like like weird sound.
Yeah.
So what they were saying is they were curious, could you put it within other music and still have it have the same effect? So I'm interested to learn more about that and see what people are doing that. Because I read another study had said that it doesn't really matter if they pair it with white noise or pink noise or something like that. It doesn't influence the beat. So I don't know.
Headspace have been doing that for a while. Have you come across the Headspace sleep sounds? They're lovely, and I really love the sleep sounds, because they have they use alpha waves, I'm going to say alpha, to try and induce that sleep state.
Yeah.
And it's lovely music. I use it during meditation a lot, and I do it in lots of courses when we do meditation, that because it's just such a lovely, deep, resonant, harmonic 2 or 3 sounds that moves from one to the other, almost like clouds passing in the sky, the way the music fit together. But it uses alpha waves to kind of reprogram how your brain waves are working to really calm everything down.
It's interesting.
Yeah, it's great for putting students to sleep while you're teaching. If they weren't already. But it's also good for patients, and actually quite a lot of people enjoy that. The only thing, you have to sign up for it before you can get it, which isn't as useful.
Headspace is cool though. They have a lot of different programs now that are really good.
Yeah, and I've just downloaded the Calm app as well, and I'm liking that.
I like Calm too. It's really good. Another one of my favorites right now for guided meditation. I really like Insight Timer. Have you seen that one?
No, what's the Insight Timer?
It's interesting because it's almost like a social media for meditation. Right. So it's there are tons of different people who put out different meditations, and it's cool because you can find what you're looking for. So if you only have 8 minutes, you could find an 8-minute guided meditation. There's ones that are based on helping with anxiety and helping someone fall asleep. And, you could listen to an hour-long meditation if you wanted to, or a 30-minute meditation. So I have found it interesting because it allows people to decide what really resonates with them based on the time that they have, and try different things. And there's another one that I'm not remembering. I'm going to have to send to you that one of my patients actually had told me about, which is really cool and has lots of variety as well.
Have you ever thought about making them yourself?
Yes, I've thought about it, but I haven't pursued it yet. I don't know. I need to see if my voice would be relaxing enough.
Well, that's the thing. It's always in the back of my mind. I used to do. I used to be taking the antenatal classes that we run at. I'm part-time at a private hospital and part-time on my own. And at the end of the sessions, we'd always do 10 minutes of guided meditation and kind of hypnobirthing type stuff and birth prep. And everyone loved it, and they were all, put it online and let's listen to you. And I was just like, okay, I'll get around to it eventually. And I never did. And it's been 3-4 years. And the same with patients when I do guided visualizations. So I do lots of, again, part of that kind of motor imagery, which I may be completely doing the wrong thing, but I'm making it up at the moment. So I do lots of guided, giving them ideas, giving them pictures and visuals of cartoon smooth organs.
Yes, I liked how you were mentioning that in your other video too.
Yeah, I think it just totally makes kind of common sense. It feels right. I think a long time ago, it's very kind of psychological CBT type techniques that a long time ago, I did some work with a dance company and sat in on a couple of sessions with the psychologist with a dancer who had broken her ankle, and she'd been doing the recovery from injury program for a year. But she'd fallen off point on stage and broken her ankle very badly. And it was during, it was something like the opening night when everyone was there to basically be picked up by professional scouts. So it was a big deal that she basically screwed up on that day. It wasn't her fault, but emotionally massive. So she'd gone through this recovery from injury, back onto point, and she could always just about do 20 minutes, half an hour going back onto point a year later, anywhere near a stage, anywhere near higher having to perform, she'd just have huge amounts of pain. And in this one session, they just got her to relax lots, talk lots about it, then got her to do a body scan and got her to take an x-ray of her ankle and discuss what it looked like. And she talked about how it was all jagged and it was red inside, and there was sharp bits and all this kind of stuff. And the psychologist just kind of said, right, I'm cutting out this section and I'm lifting it. Right, I'm putting in a new one, and it's got white smooth bones, and when it fits in they completely lock into place, and it's really smooth, and the surface around it is special and strong, and all this kind of really simple imagery really got her to think about how strong and wonderful that felt. And that week she got up on stage and performed and was fine. But it was about reintegrating this visualization of a strong, stable, safe ankle, which is part of the motor imagery. So I do lots of imagining whatever a healing color is to them. What is it, a soft color or a relaxed color? Imagining doing a bit of mindfulness for 5 or 7 minutes, and then imagining that the organ is smooth and soft and colorful and relaxed and all this kind of stuff, and getting them to repeat that. And a lot of people, when you talk to them enough about why it happens, they're okay with it. But to begin with, they're like, what? This is physio? Where's my sponge? Yeah, exactly. I thought you guys just like played, you were at the football pitch. Exactly, running on with our baskets. But the graded visualization works pretty well. And I also do stuff like for the more I've got an athlete at the moment that we put a Kevlar pelvis into to make it strong, because it was she was having leakage when she ran, and I'm pretty sure it's just to do with neurotags of environment and habit and fear and lots of other stuff. And since she's had this Kevlar pelvis on, and I made her go and stand, imagine running in the new running track, and stand at the new running track and imagine doing it, but not actually run, and then finally go for a jog, not a run, on the new running route, but with her Kevlar pelvis in, and she didn't leak.
That's amazing.
So it's trying to create new ways. So I like Headspace just because it gives you kind of like that first 10 minutes, and then or the sunshine through your head, and I can tell to patients, right, that's the color, whatever color you think is the healing color or the relaxed color, we're going to put that into your body, just to try and give them a different perception of what their body can feel like, because it's very easy to say, this is how my body is, you will not change it.
I liked everything you were saying. It's just, I think that visualization is cool. I need to do more with that, because I really love what you're talking about, and I don't think I'm using that as much as I could be with my patients. It
feels a bit bonkers for a while, and then it gets.
No, I like it. I'm in. I've tried. I've done a little bit of that. We've done having patients even like looking at magazines and finding pictures of people in positions that are bothersome, and trying to see what would it feel like for them in that position, and what does their pelvis feel like versus, and then taking and putting it on themselves. But as you were speaking, it just was highlighting to me again that importance of language and how powerful language is. And I think in working with a pelvic population, whether it's pain, but also with people who struggle with leakage or with prolapse, or they can tend to feel so broken. Yeah. And unfortunately, they'll get these messages from other providers that can end up putting that visual for themselves, like the patient you were mentioning with feeling jagged and feeling all that. I've had patients come in with their pelvic floor, and their first visit, they'll say, well, I saw this person and they said it's a mess down there.
Stop saying that.
Yes. Or they'll say like, oh, they said everything was so thin, everything so weak. And
then they're terrified that it's all like, if they move fast, that everything's
and it creates this huge overriding danger
Yeah.
where people feel like they can't do anything. And I've had many patients, their first visit, they come in and they have stopped all their exercise they're doing. They, you know, they don't even want to lift their children because they feel like lifting their child is suddenly going to break this delicate system that they have. And so I think that we as clinicians, the power of our words in helping someone feel, okay, you are not broken, you are strong, your body is strong, your body is adaptable.
Yeah.
That is so powerful. And I think that we have to take that responsibility, that we can either be a facilitator in someone's healing, or we can play into their fear and keep them down this road of fear and activity, you know.
It's absolutely, and that's kind of what I was talking about with the sitting in the vulnerable space with the patient. There was somebody the other day. I make the effort now to really kind of lean in and go, you are robust, you are fixed, you are healed, you are strong, your spine is strong, you know, that kind of listen to me. And there was occasionally I get, stop it animal, occasionally I get I'm really sorry, you've got a toddler who is behaving better than my cat currently. We have I have quite a few international patients that come over for kind of 2 weeks of blitz treatment, which is a lot of talking. With the last one that I saw that's gone back off to Europe somewhere, he recorded quite a lot of what I was saying. He was just like, I just need to hear that said to me. And I was like, okay, you are strong, you are robust, you can do these things, you have done these things, you've done these things with me. You know, getting them into squat positions when they don't think they can get into a squat because it's too painful of a bend, but then you do it upside down and they're like, oh, I can squat. Because then you get them into this position, they go, yeah, this isn't too bad. And you go, okay, well, you're in a squat position, you're just not loaded. Let's practice loading. And showing people that actually they are really robust. My favorite, you know, when you get those really easy days, and maybe it's just because I've done this long enough now, that when they come in, they say, well, the doctor says that, and I'm not blaming all consultants, because the consultants they can be fantastic. And sometimes, you know, we have off days, they have off days. One lady that came in with a huge history of pain and kind of 50 years of lots of issues, but actually she was referred with a cystocele with anterior wall prolapse for pelvic floor training, and was gripping like mad because she had 50-year history of pelvic pain, dyspareunia, 3 previous pelvic surgeries, and didn't want another one. And go on then, photograph, there we go. And she came in, and what she said to me was, oh, the doctor says it's gone, my front wall's gone. And I was like, where's it gone? Where'd it go? Not fallen off. It's definitely there. It's at least 0.5 centimetre thick. But you know, just an off the cuff remark, yes, you're definitely going to need the operation done because your front wall's gone. It's the turn of phrase. And you know, your front wall gone actually just means that it's got enough of a laxity within it that it's going to create symptoms longer term. And actually she was very, very tight. So I like to say Mountain Mohammed Mountain. Instead of the prolapse being low, her pelvic floor was high. So she was more aware of it, and she had friction because she was dry and dyspareunic and postmenopausal. So we gave her some lubricant, gave her some desensitization, talked to her at a great length about anatomy, and told her what the consultant said was just a different way of saying what we were saying. And actually it doesn't mean it's actually dead or gone or destroyed or whatever. Immediately fine. 50-year history of pain gone.
So powerful.
Yeah,
so powerful. That's awesome.
So our words are worth more than we know, but I think we could probably talk about this forever.
Forever and ever and ever.
Nocebo language. It's my new, I've got a whole section of my course about let's talk nocebos, because if we say to our postnatal population, you've had this massive trauma, don't run, then they never will. Or don't pick up your baby. They never will. So what we need to say is, we'll come in for an assessment, let's see how you're doing, and actually let's progress you back to exercise in an appropriate manner. Getting back to CrossFit is great. Getting back to the gym, lifting, squatting heavy is great in the right strategy with the right movement. And as long as they don't get too bogged down with, is my strategy perfect? Then, you know, then it's fine. So we should be empowering, not kind of diminishing. But I think it's, I think the more I learn, the more that I realize that none of this is rocket science. the
Yeah.
science is really interesting, but a lot of it really isn't rocket science. And actually, we need to be less precious about, you must do this hip rotation, strengthening, cool exercise with a bit of TheraBand, and just get people moving.
I remember one of my favorite professors from undergrad said that the more you study about the human body, that it should lead to both a humility of the intellect and a humility of the spirit, that we should, like you were saying, we should learn, we should see that everything, the body is just so fascinating and so complex. And the more we understand about it, the more we really realize how much we don't know about it. And we complicate things that don't need complicating. And, I don't know. I don't think we understand why things work as much as we think we know how they work.
No, absolutely. And I think it's really healthy to keep a good rein on that, so that, we're both really clearly really interested in the research, but the research will change and it will grow and it will adapt. And what we're doing is the best of what we can with the available knowledge. And give 10 years time, this talk, we might still be doing this. We might be doing something completely different, depending on what comes up.
And I think that it's important as a clinician to keep that in mind. Several professors have had these little quotes that stick with me, but one of my professors when I was in PT school actually said that if you reach a point in your clinical practice where you're not willing to completely throw away everything you do for something different, then that's the point that you should retire. Yeah. And I always try to keep in mind that no matter how much I like a technique I'm learning, that I have to always be willing to change. And if something new is coming out, I have to be willing to throw away this thing that I have invested time into, because it's no longer the best way to treat people.
Absolutely.
And that's tough to do, because confirmation bias is real. And when you treat we all, I think, are prone to thinking that what we do is effective, instead of examining and thinking, is there something different we could do instead? So.
Yeah. Are they just healing? Are they just getting better on their own?
Yes.
Is something happening? Yeah. Another favorite quote of mine is, hold loosely to your theories. Yes. Because you should be able to give them away. That's another Sandy quote. But you should be able to move forward. But that's really hard, and it's certainly hard when you don't feel confident enough in yourself and what you're doing. So hopefully, if anyone's listening to this, they should hear that two clinicians are completely making it up. But with
I think we have a decent amount of experience in pelvic health too, right?
Yeah.
So if we're making it up, then it's cool to make it up.
Yeah, absolutely, because that's the only way that we can grow and learn. And that we do the best to not get it wrong, but we will get it wrong. And at the end of the day, we're trying, and this is what being at the forefront of medicine looks like.
Yes.
Yeah. So anyway, thank you very much for talking to me.
It was a pleasure. It was wonderful. I loved it, and it's really cool that in our time, I'm always blown away that we are connecting. We're sitting here video chatting. And I mean, you're like 5 hours ahead of me, or 6?
Yeah, it's 4 p.m. now.
It's 11 a.m. here. I mean, It's amazing. Yeah, but I hope we can connect and meet in the future. And this was just awesome.
Yeah, I'd love to. Well, I will be at World Congress of Abdominal Pelvic Pain in London next year, definitely, if you fancy coming over for it.
Oh, I always fancy coming over to London. I need to make that happen.
Yeah, so get yourself over to London, and we will have some drinks in London and say hi and chat, I'm sure, for hours about all of our combined, because it sounds like we're really on the same page, which is really great to hear, because again, I try and do these chats as often as I can with as many different people, and you guys in America have so much more access to higher level thought processes with regards to pelvic pain. So kind of really digging into access to the researchers, access to different pain programs and different.
See, I feel like you guys are doing such cool things over there.
Maybe it's just the grass is greener, but
seriously.
But so it's good to connect and see that actually on a worldwide level that we're all kind of at the same point and we're working things out. So if you, I've gone back through your blogs, and if anyone's, hello, I'm trying to find my little boxes. If anyone's watching this, go have a look at a blog. I'll put links to this underneath.
Thank you. Appreciate it.
Because it's great. And also to Seth's blog as well, which I found really, really interesting. He's a lovely guy, and actually I really like what he's saying with movement and fear and
stuff. Yes, and I'll give a little shout out. He actually has just started teaching, and he just course that's a 2-day course on stress and movement, and how to use movement to help a stressed out system. And it's a really cool dynamic course. So if any of you are interested, check out his website, and he has links to that. They are in the US. And so if you're here and interested, check it out. Or if you fancy a trip across the ocean, come on over
absolutely
here.
I'd love to. At some point I will make a trip across again. I managed Washington last year, but maybe not for a few years, but I will be back over. But
Awesome.
yeah, it's lovely to catch up. And if as and when you're doing new stuff with patients, please put it online, and we'll chat again, I'm sure, at some point soon.
Yes, I want to chat about the vestibular system with you, so we have to do that at another time.
Okay,
because that's interesting too.
I'm intrigued.
Yes, be intrigued.
Okay, well, it's been really, really lovely to speak to you. Thank you for giving me so much of your time and your brain and your knowledge.
It's been great.
And we shall talk soon.
Sounds good. Talk to you later. Bye.
Bye.